All right. Good evening, everybody. We are back for day 2 of the 4th annual Virtual Diabetes Symposium. If you were here last night, this is going to sound familiar, but I am Sarah Bloom, the Executive Director, and Kimmy Moore is our President. The Diabetes Coalition is a statewide nonprofit organization comprised of different healthcare organizations working together to improve the lives of all people in Delaware affected by diabetes. We meet quarterly, and we also do 2 events a year, this being one of them, and our annual expo in November. And that is more geared toward patient education, and vendors come as well. So the reason that we started this event is because we have a college scholarship for $1,000. The deadline is April 30th of every year, and I very rarely get more than 1 applicant. So please tell your students and pass the information along, and let them know that it is available to current students in college. They just have to be a Delaware resident, as well as high school seniors, and it's open to type 1 and type 2 students with diabetes. A new program that I'm excited to share is we did receive a grant through the Lions Club International. John Monahan is on our coalition, as well as Amy Hastings is a school nurse in the Appoquinimink School District. And we partnered with the Department of Education to apply for this grant to get education, online training education for school nurses, as well as teachers, coaches, bus drivers. And this will be a 2-year program. And the training is available the grant will fund for 2 years and be open to every school in every district throughout the state, both public and private. We did do a pilot program. The coalition did pay for 25 licenses. That's for 1 in each school district throughout the state. If you are a lead nurse and are not aware of this, please let me know. I'd love to get a license out to you. We have not had adoption of all of the licenses, so we'd love to put that into play. This grant and the overall across the state lines, or across the state, will be implemented in March or April of this year. So to get your continuing education tonight, you have to watch the 120-minute webinar live. You have to complete your evaluation by March 1st. I will put it in the chat after the meeting tonight. And so I highly recommend just fill it out now so you don't forget. And you will receive your certificate probably by mid-March. And you will get 2 hours in any of those different organizations. Speaker disclosures are on our website. Tonight's learning outcome is the same as last night. So attendees will report an increased knowledge of available type 1 diabetes screening, ways school nurses can support families of children with type 1, and how formalizing a transition process from pediatric to adult endocrinology clinics will aid in the student success. So with that, I will stop sharing. And Sarah Ogilvie is our first speaker tonight, and she's going to talk about the importance of school nurses and how you can assist with patients with diabetes and their families. And then Dr. Phan, we found through the CDCES magazine, and she's going to talk about the transition from pediatric endocrinology to adult. So with that, ladies, I will pass it off to you, and thank you so much for being here.
Okay, I'm going to share my screen. Let's see. It's really an honor to be here to speak with you tonight. My name is Sarah Ogilvie. I'm an assistant professor of nursing at Minnesota State University, Mankato, and I'm also the clinical coordinator at a school-based health center called Health Commons at Pond. But I wanted to tell you, I do have some ties to the Mid-Atlantic region. I went to nursing school at the University of Pennsylvania in Philadelphia, and I've been to Delaware many times, and it's really an honor to be asked to come and speak to you and to be able to speak to an audience of school nurses. I did spend several years myself working as a school nurse, and so I know there's also dietitians and pharmacists here as well, but I was told that the audience is mostly school nurses, and so I feel really honored to be able to address you today. I think that the work that you're doing is so important and so important for children. So I tried to really gear my talk towards that. The learning objectives today are to better understand the burden of care for families of children with type 1 diabetes, understand how school nurses can help families with problem solving and strength building. These families really have a lot of struggles, and I think school nurses are really in a position to make a huge difference for these families. I think you guys know that. You are in the front lines doing this, and also dietitians and pharmacists. I want you to understand how you can help families with teamwork, both within and without the family, to better cope with the burden of caring for their child. And also understand how to help families better cope with the burden of uncertainty. That was something that came up a lot in our research. The other talks that you're hearing in this symposium are really technical, and my talk is going to be a little bit more qualitative or touchy-feely, but I hope that you'll learn from it too. So a lot of what I'm going to talk about today comes from a project that I've been working on called Thriving with DM Beyond the Numbers. And this is a research project that I've been doing over the past several years that has a few different components, but it's a partnership among a few different partners: Minnesota State University School of Nursing, Health Commons of Pond, which is a nurse-managed free health clinic. I'm going to tell you a little bit more about that, just so you understand the context of the work that we're doing, and Bloomington Public Schools, which is a diverse suburban school district near Minneapolis, Minnesota. And we're kind of a first-ring suburb that has a lot of challenges. And we did get IRB approval for the work that we've done. This was approved by the MSU Mankato Human Subjects Institutional Review Board. A lot of several of the slides that I have are going to feature some artwork from children. Each of the children who made artwork were impacted in some way by diabetes. And so, for example, this is a digital drawing done by a girl age 15 called Broken Pancreas. We ended up using it as the logo for our Thriving with DM Beyond the Numbers project because we thought it was such a fun artistic rendition of a pancreas. Anyway, so I hope that you'll enjoy the artwork that we have throughout this presentation. So Health Commons at Pond, the clinic that I work at as part of Bloomington Public Schools. This is a picture from the clinic. This is the only one I could find of me at the clinic, because we usually don't take very many pictures of the clinic, so I don't want to show patients. But this is me with Alyssa. She's a volunteer Spanish interpreter. So this is us at the clinic. We're located on the campus of one of the high schools. Bloomington Public Schools has two really large high schools that have about 4,000 or 5,000 students. I think we're on the campus of Kennedy High School, which has about 4,500 students. So we have really big high schools in the Minneapolis metro. And we're kind of on the high school campus, and we're in the same building with the Head Start preschool. So this allows patients that want to come and see us at the clinic to be able to walk over from the high school. And then we also are really convenient for the students and parents that are going to the preschool. And then also there's, a middle school and some elementary schools close by as well. So Health Commons at Pond, we serve the kids of Bloomington Public Schools. We support the school nurses of Bloomington Public Schools. They can send students over to see a nurse practitioner for a visit. We're a free and charitable clinic. We don't charge anyone for our services. We do free health visits for medical problems. We are part of the Federal Vaccines for Children program, which means we can vaccinate kids that don't have insurance, and we can vaccinate kids that are underinsured, which means kids that are part of the Medicaid program. We do free sports physicals. We often do mental health counseling, and this is provided by MSU Mankato Masters of Social Work students. And right now we're seeing an overwhelming need from new immigrant families for healthcare. We have a lot of families coming in to Minnesota from camps at the border of Texas, and they're being kind of housed in temporary housing in Bloomington. And it's really important for those kids to get into school. And in order to do that, they need to get their vaccinations updated. Some of them are coming with no records. So our clinic has been really, really overwhelmed with all of this. And then we also provide educational opportunities for nursing students, both bachelor's level students and students that are doing clinicals for their nurse practitioner doctoral program. And then we do ACEs screening, which is adverse childhood experiences screening and social determinants of health screening, so that we can try to connect them with resources. For kids that have a lot of adverse childhood experiences, we try to connect them with therapy and support. And for kids that are at risk for food insecurity and things like that, we are trying to connect their families with resources. So we do a lot of things. And I don't know if you have these types of health clinics in Delaware, but I just wanted to tell you about what we're doing in Minnesota, so you kind of understand where I'm coming from. So we've been doing this project on diabetes because we found that the school nurses in Bloomington are spending a lot of their time with the kids that have type 1 diabetes and have needed some more support on that. And so it's been an area where we could contribute and support the school nurses at Bloomington. So to tell you a little bit more background and purpose for my talk today, just to put things into context, and you guys probably already know a lot of these numbers, but there's been a big increase in the amount of type 1 diabetes that we're seeing in children. Type 1 diabetes currently affects about 0.3% of children under age 20 in the United States. These are CDC statistics. This is about 244,000 children and adolescents, which is a lot. And I just want to note that I had to update my slides. This was an increase of 187,000 children from the CDC statistics for 2020. So that's a pretty big increase in just 2 years. So if you guys feel like you're seeing more kids with type 1 diabetes, you are seeing more kids with type 1 diabetes because it's really increasing. And we'll talk about why that is in a minute. And I also want to make the point that fluctuations in blood glucose affect children's school performance and family life really profound ways. And so that's really important to think about. And the National Association of School Nurses has addressed this. Their statement from 2016 said that diabetes care is a critical function of school nurses. And yet, and also that adequate staffing of school nurses is really important for students to have best school performance with chronic illness. And I know that I've personally worked as a school nurse. I've worked in Minnetonka School District in Minnesota as a school nurse, and I've experienced the struggle firsthand. I know that my type 1 diabetes students did take a lot of my time in my day and required a lot of my attention. And so it was really important in order to keep them safe and functioning at school to be able to give them that time. So to kind of put things into context, I have a quote. This is from a 16-year-old that I took care of that had diabetes when I was a school nurse. And I remember him saying this, I can't think very well when my blood sugar is too high or too low. And so I want to just frame what we're talking about today with this message. Kids can't learn or function well at school when they're having problems with their diabetes and their blood sugar. So I think it's really important to remember that. How can we help and support these kids to have a great day at school every day? And so it's really important to help them to have their blood sugar within good parameters, because they can't learn, they can't do other things, and they can't enjoy their day at school. So just to frame some things from the literature, there's a lot of factors that impact these families and children with type 1 diabetes. Some of the things that we found as we were researching this topic is that there's a lot of family factors that go into things. We found that family structure was really important. A lot of times families that have a single parent really struggle because all of the burden of taking care of the child with type 1 diabetes rests on one parent, and there's really no breaks for that parent. It really becomes hard unless they have other support people in their life that can help out. And income can also be a factor, because in order to function well with type 1 diabetes, you really need access to good health care. You need to be able to take time off from work sometimes. Things like that can really be factors. Another thing that can make a difference is coaching families with parenting interventions. We'll talk about that a little bit more further on in the presentation, but a lot of these families face a lot of stress around the diabetes crises that they go through with their child. And so if patients can coach their child with diabetes and not react in a way that implies being upset or stressed out, that can help a lot. the family experience tends to put the mothers as the expert on the child's diabetes. They tend to be the ones that take the biggest burden of caring for these children. There's also a significant impact on siblings. And there's not a ton of research on siblings, but there's just some new research coming out. There's a couple of older articles, but there's also some research being done right now in Australia. But these people always think, oh, the sibling is fine. The sibling is definitely having an impact. These siblings are experiencing stress. They're sometimes experience some jealousy because their other sibling is getting the sibling with diabetes may be getting more attention and time from the parents. They often feel a feeling of vigilance. They worry about their sibling that has diabetes, and they can have all members of the family may experience stress and post-traumatic stress symptoms. So that this chronic illness does impact all aspects of the family experience for all members of the family. It's important to not assume that the siblings are fine. Improving self-management. It's really important to help these kids to function well at school. We found that many times people just expect that these kids can go to a session with the diabetes nurse at the doctor's office and just learn how to take care of their diabetes, and that's all they're going to need. And that really isn't how kids learn very well. Kids tend to learn a lot better kind of having some coaching, handling situations as they come up. And a lot of times the school nurse might be the person that can coach that child to learn how to respond when their blood sugar is going up or down, and learning how to cope with those different situations as they come up, and having an adult like a school nurse helping them, like, well, what should you do now? What do you think we should do? And having them think through that and develop some more independent skills can really make a difference rather than just being expected to learn it all at the doctor's office. And it's also true that a lot of times doing some psychosocial interventions, things like helping kids connect with other peers with diabetes and feel supported, can be more effective than teaching them an educational module or something like that. And then we also found in our research, as we were looking at background information, that increased collaboration between providers and school nurses really improved adherence and learning for the child. So if nurses can get involved with that relationship, so there's kind of a triangular relationship, school nurse, parents, and the child, so everybody's involved and on the same page as far as the care plan for that child, that can really make a big difference. The child is spending a significant percentage of their time at school. Some other things that we found is that there's a lot of stress and uncertainty for these families. These are big concerns for these families of children with type 1 diabetes. These parents don't know when they're going to get called and have to pick up their child, or when there's going to be a crisis, and that can be really stressful. They're constantly worried about their child that has type 1 diabetes, especially if their child is a little bit of a brittle diabetic. It can be really, really stressful. And then the child and teen perspective, children and teens really need assistance and support in developing healthy coping strategies. And school nurses are really positioned to where they can discuss challenges and provide support and help these kids to develop those strategies. And they really benefit from the opportunity to ask questions from the school nurse, because the school nurse is perceived as like a neutral, supportive person who's not going to react in an emotional way. And the school nurse also sometimes can help connect them with peers who have type 1 diabetes, and that can really help them with coping. Like talking to another kid who has diabetes about what they do can be like the most powerful way to help that kid to learn how to manage their diabetes. So as we did our research, one of the things that we emphasize a lot at MSU Mankato is family nursing. And so just taking a little bit of a step back, I think it's really important in doing this type of research to always make sure that you have a clear definition of family. And so for this research, we used the Calgary Family Assessment Model. And I don't know if you guys remember this from nursing school, but the CFAM, or the Calgary Family Assessment Model, says that a family should be self-defined. So this means it's not necessarily a mom and dad and X number of kids. It could be however that family defines itself. And so there's many families that don't look like a traditional family. They may have other people who are significantly involved with them that they consider to be their family. And so they may be related in a traditional way or not. And so we asked the people that we interviewed in our study who they considered to be their family. And this is an example. This is a drawing by a child who participated in our study who has type 1 diabetes, and she drew her family. And in her case, we have a mom and a dad and 3 kids, 2 girls and a boy. She has all the girls have these fancy eyelashes in this picture. It's really cute. And then she also has a grandma drawn in her picture of her family. And this grandma provides a significant amount of support to her family. She comes over almost every day. She gives the parents breaks. She knows how to take care of the diabetes. And that has been something that has helped their family to function much better. Having a third adult involved who's able to help them with the child with diabetes has been really key. And so that has helped with their family functioning a lot. And so that's how this family would define themselves, as having, you know, their traditional family plus this grandma who lives really close by. So family dynamics, having a child with type 1 diabetes, as we talked about just now, in the family impacts all members of the family because it impacts resources, time, money, and attention. These are all limited resources, and the child with type 1 diabetes, this type 1 diabetes tends to use up all of those things, time, money, and attention. It impacts the siblings. They may have increased stress. They may receive less attention. They may also feel like they have to be vigilant about their sibling. It causes stress on the parents and the parents' marriage. There's a quote from a single parent from this study where they said there is no break. She didn't have anybody who could give her a break in caring for her child. And then we found that families with a teamwork approach really have reduced stress. We found this in literature. We also found this in our study. So if that's something that you can encourage as you work with families, that might be a really great thing. Because if, you know, sometimes in some of these families, the mom is kind of the expert on the diabetes and the dad doesn't learn how to take care of the kids, or vice versa. And so if they can have more than one adult in their family structure learn how to care for that child, it can really make a big difference. Just like in this picture of this family drawn by this child, we have 3 adults who are all capable of taking care of the diabetic child independently. That made a huge difference for them because they could hand off, the parents could go and do an activity together without worrying. When you have a teamwork approach, there's that ability to have a night off or to get a full night's sleep or things like that. That can give you reduced stress. And so encouraging families to find another trusted adult who can get involved with the care of their child is really important. Or if only one member of the family knows how to do the diabetes cares, encouraging them to, you know, more than one member of the family to learn can be really helpful. So the COVID pandemic, I mentioned earlier in the presentation that this has had a big impact. It was interesting when we first started the study, we had lots of families signed up to participate, and then like 3/4 of them dropped out when COVID started. We started the study right before COVID happened. And we found that the stress of families of children who have type 1 diabetes during the COVID pandemic was magnified, even more than everyone was stressed during the pandemic, right? But the families that have children with type 1 diabetes were even more stressed. And so why was that? We think it was worse for the families of children with type 1 diabetes. These families faced even more limited childcare options because they couldn't, you know, I know at the school that my kids went to, they had some childcare for healthcare providers, but there wasn't a school nurse there. It wasn't like a regular school day. So if I had had a child with type 1 diabetes in my family, I couldn't have left my child there. I wouldn't have felt comfortable. But, you know, I did do some work as a healthcare provider, leaving my kids in that childcare because I don't have a child with type 1 diabetes. And I was able to use that. But if I had had a child with type 1 diabetes, that wouldn't have worked. Access to their healthcare providers was much more limited. There were a lot more telehealth visits, a lot less face-to-face. They felt like they didn't have as good of communication about their child's care. They had a lot more worries about their child being vulnerable because their child was one of the at-risk populations. If they got COVID, they could get more seriously ill. So they had a lot of stress about that. And then there was this issue with disrupted routines. As you guys know, when you take care of a kid with type 1 diabetes, you kind of need to know their routine because that kind of determines how much insulin they're going to need. And when you have a routine that's not consistent, if they're getting more outdoor time or less outdoor time, more activity, less activity, that changes it all. And so then you don't have as good glycemic control. You don't know how much insulin to give. And so a lot of these disrupted routines became really stressful. Now you have a kid that's home, they're not on a routine at school, and you're trying to do work, and you have a kid that's going in and out. It does not have a consistent routine. So this became really hard. And then we also had a big increase in new onset cases of type 1 diabetes. As you guys probably know, a lot of times diabetes will happen after a viral illness, and COVID is a viral illness. And so around the time of the pandemic, we also had a lot more new onset cases of type 1 diabetes. And you saw that in the statistics from the CDC in my early slide. So for this project, we used a theoretical framework, the Revised Self and Family Management Framework from Margaret Gray. I won't get into it too much. You know, I'm a nursing professor, so I got to have like a theoretical framework. So I'm going to jump to the next slide. We did find that we felt that we could really impact the facilitators and barriers and the processes that these families were experiencing, and that would really make a big difference on outcomes. So I kind of summarized that on this slide. My conclusions here are that school nurses have the possibility of impacting proximal and distal outcomes. So, you know, on your body, proximal is close and distal is far out, like on your arm or something. And the basics is that this makes a big difference. I would say proximal outcomes are things like behaviors, self-efficacy, motivation, stress management, things like that. And distal outcomes are kind of the more long-term things: morbidity, mortality, quality of life, provider relationships, family functioning, and an impact on patterns for life. And so we really think that school nurses have the possibility to impact both these closer in outcomes and the long-term outcomes for these kids. You can make a big difference in terms of how they're going to handle their diabetes for their whole life. So we did family interviews with families of children with type 1 diabetes. And what I want to get out of this, I'm not going to get too much into our whole methodology and all of that like I have in some of my scientific presentations at conferences, but what I want to do is really give you a flavor for the lived experience of having a child with type 1 diabetes. And I think you guys probably already have that from taking care of these kids at school, but I'm going to share some quotes and things because I think they're really powerful. So for these family interviews, we did Zoom interviews that were about 45 to 60 minutes with 2 to 3 researchers present. And we're able to do this during the we were originally going to do them in person, but you know, the pandemic happened, so they went over Zoom. But that actually was really nice because then we could record the interviews and get a good transcript from them. And then we used the self-defined family, which is the family however they wanted to define it. We encouraged all members to participate, but what was required was at least one parent or guardian and the child with type 1 diabetes for the interview to go forward. And then if the child didn't want to participate, or at least one parent didn't want to participate, we didn't go forward with it. And then the interview was recorded and transcribed for analysis. And then we created a genogram and econ map for each family. And what we were trying to get at was kind of more information about this lived experience of having a child with diabetes. And then we're going to use some of this data to develop some school-based programs in Bloomington schools to work with these kids. So we started with like 20 families signed up, but then a lot dropped out because of the stress of the pandemic. So we ended up with just 5 families recruited from different places in Minnesota. Each had different family structures. We had some suburban and some rural families with different levels of participation. They were from all different areas, not just Bloomington. We had different ages of children, some with special needs, and we created a genogram and an eco map for each family. I'll show that. And so our goal today is going to be to better understand the lived experience of these families based on what we found out at these interviews. So here's a little bit more about the families that we interviewed. So you can see some of them were a more typically functioning family with 2 parents and children. We had that family that had the grandma really involved. We also had a family that had 3 diabetic children. And these children were all teenagers. So that was really interesting. And they were a really high functioning family. So we learned a lot from them about how to be a high functioning family with diabetes. And then we had a single mom with some special needs, but she had there was a grandpa really involved with this family. That was super helpful. And then we also had a foster mom and a child, and she was really struggling. So we kind of got lots of different perspectives, and we did reach data saturation. As you know, with qualitative research, that's kind of the goal with interview data. And sometimes you don't need a big sample to get there if you have good quality data. So here's an example genogram. I kind of changed this so you couldn't recognize exactly which family it would be, but we were trying to understand the family structure and who was involved with each family. This gave us some good information. So this was how we would draw a genogram. Maybe you drew genograms back in nursing school. I certainly did. At Penn, we did that. And here's an example of an eco map. And this is actually one from a family that was in the study and then dropped out, but they said I could still use it. So this was kind of an interesting one. And I highlighted the school nurses in pink because I wanted you to see how significant this showed up on almost every eco map, that the school nurses were really significant in these families' lives. So you can see that this family had 3 kids. The one with diabetes is the one with the asterisk. And so we were highlighting some of the different activities and supports that she had. They were really involved with church and work, with their endocrinologist. This mom got a lot of satisfaction out of going to the gym. That was her self-care. But she also still maintained this child with diabetes was 16, but she still had really strong relationships with the elementary education, the elementary school nurses that she had worked with this child. This child was now in, I believe, 10th or 11th grade, but she still kept in touch with her previous school nurses from elementary school. And this was because they had become such a resource and they'd been such good friends after talking pretty much every single day of elementary school, that these relationships had stayed strong. And she said that the relationships with the school nurses at the high school were not as strong. There's several school nurses at the big it's not Bloomington, it's a different big urban high school that has 5,000 students. And so she didn't know those school nurses as well. There was, I think, 3 or 4 school nurses at that high school, and she didn't know them as well. And they weren't quite as involved. Her daughter's more independent with her cares now. She does still talk with them frequently, but and she does really depend on them with her daughter, but she still had that really significant relationship with her previous school nurses. So I wanted to highlight that and how important that was for her, for the family, both the daughter and the mom and the dad. So I want to go through some of the themes from these interviews, and then I'm going to use that to make some conclusions towards what we want to do with our family programs, and then with things that school nurses can do based on this. So the first theme that we found was facing stress, strains, and struggles of management and network, that it was a heavy burden. And I just chose a few quotes to highlight this. We had like a lot more quotes, but these ones kind of illustrate this message. First quote is, "There is no break." This was from a single mom. Another parent said, I think it's the no break, and the no break for him too. That's the kid with diabetes. There's another parent said it's a lot of heavy sometimes. Another parent said it feels like an insurmountable wall sometimes. So you kind of get this feeling of how much of a burden this feels like for these families. And this one is another related theme, negative emotions related to diabetes. One child with diabetes said, "I do not like diabetes." I thought, well, that's pretty okay. Another child said, "Some of them," meaning other kids at school, "don't like it," meaning that and the context of that was that he gets extra attention. So I thought, well, that's something to be aware of. That's something that maybe school nurses and teachers can help with. Another caregiver said, "It's very bad when I first heard about it, but I got through it and then dealt with it logically." And she also said, "It's in your face. This is real." And then facing stress, strains, and struggles of management and network. One family said they used to love to eat out at their favorite Mexican restaurant, but now it's not so pleasurable. And this family was not super educated, and they found it really hard. This Mexican restaurant that was their favorite in their small town did not have any, in Minnesota, they're not required to put the nutrition information on the menu. And so there wasn't nutrition information on the menus. And so they had a really hard time figuring out how many carbs were in the food at this Mexican restaurant. And so they found it really stressful to go out to eat at the Mexican restaurant that they'd always loved. And that was their Friday night place to go. And so then it became not very fun, because then they would stress out about what their kid was eating and trying to figure out the insulin and everything. And it just became not fun anymore. So that was something that was a loss. And that's something that you would think of as just being a normal activity. There was also an experience of vigilance to protect the child. One parent said, I get really paranoid about going to bed because she'd had to give glucagon at night several times. Another parent said, we constantly have to think of it. It's like brushing your teeth or showering on a daily basis. It's always on the mind of the parent. And as you know, sometimes kids can go low with their blood sugar in the middle of the night, and that can be really stressful. We talked about being a family as a team and how that affects all members of the family. And it was interesting. A lot of these families didn't really think that diabetes was affecting the siblings. And that's been something I've talked with my friend who is from Australia and is doing research on siblings as well. And a lot of the families think, oh, the sibling is fine. The siblings are fine. So we were doing an interview with a family, and this was the family that ended up dropping out, but they said we could still use this artwork. And so this child, age 7, was the younger sibling of the girl, age 14, that has type 1 diabetes. And they said, oh, our younger daughter, we'll call her Lily. Lily doesn't even know that her older sister has diabetes. She has no awareness. We never talk about it with her. We don't think she even knows about it. We just handle the diabetes, but Lily it doesn't impact Lily. So I said, oh, that's really interesting. Let's ask Lily about it. So I said, Lily, would you like to draw a picture? Could you draw a picture of diabetes? And it was interesting that Lily said, oh yeah, I know about diabetes. And she drew this picture right here that you're seeing. And if you remember, I don't know if you've ever been involved with diabetes education, but there's this bear you can buy. That's the injection site bear. It has spots, and then there's like for injections, and there's a pretend syringe that you use with this bear. So anyway, she drew a picture of the injection site bear, which if you've seen that bear, you'd recognize it. And she drew it really big. And then she explained that diabetes is a really big thing for my sister to deal with. And that's why I drew the bear really big. The bear is diabetes. And she's like, I know it's something really big that my sister has to deal with all the time and my parents have to deal with. And so they were like, oh, I guess she does know about the diabetes. Maybe we should talk with her a little bit more about it. So that was kind of a moment of understanding for that family. And so I think even just encouraging families to talk about it so that the siblings can process those feelings is really an important thing that you could coach families on. Navigating barriers and accessing resources. A lot of families expressed frustration about dealing with insurance. Even those families that had good insurance experienced the feeling of going into battle and having to get things prior auth and pre-approved over and over again. One family felt blamed for her child's diabetes. She lived in an apartment, and one of her neighbors, she doesn't know which one, called Child Protective Services and reported her for giving her child, quote, too much sugar. And she received a visit from Child Protective Services and showed them how she keeps track of all the things that he eats and that does his insulin and everything. And Child Protective Services told her she's doing a good job and left, but she felt really, really violated by that experience. Navigating barriers, there's disconnects in the healthcare system where people just don't understand. A lot of kids going through puberty will have a higher hemoglobin A1C, and the family with 3 diabetic children reported being sent to the nurse educator and over again during their kids' years of puberty and being threatened with, your child's going to lose their eyesight or have kidney damage. And that mom said, I don't even want to count how many times I've seen the piece of plastic mashed potato and the little plastic cup of milk. We've had to see the nurse educator to count carbs so many times because the doctors just don't know what else to do. And they just assume it's their fault that there's a high hemoglobin A1C, when maybe it has to do with puberty and hormones and all these changes with growth. Stress during the pandemic. A lot of times people, like I already mentioned before, instead of getting appointments, they had to do virtual and play phone tag and things like that. And one of the moms said outside, inside even is a challenge, meaning the disruptions to her child's daily routine made it really hard for them to keep the diabetes under control. But there are also some positives. One mom found a lot of support on Facebook. Another mom said the teacher and principal let me go to his classes and talk to them about what it's like. And we've read books to his friends and he's educated them. The teachers have let his friends in class walk him to the nurse's office. So that's something that can be a safety thing too, and also help that child not feel so alone having to leave class, and also help those friends not feel jealous. The relationship with the school nurse can really make a big difference. He's got a really great nurse at school. She was with us from the beginning, but then they found that there was a lot of stress when they went from elementary school to middle school and middle school to high school. So that's something that maybe school nurses can help with, helping that child to be a little bit more independent, but then also helping the family transition and meeting the new care team at the middle school or the high school. And this is something that hadn't really been documented in the literature. There's quite a bit about transition to adulthood, and you're going to hear about that from Dr. Phan today, but there's not as much about these transitions to these bigger schools, middle school and high school. In Minnesota, the middle schools and high schools are really big in our metro area. So that's an area where you can help with stress. Relationships with the medical provider, those are really important. And it's really important for them to find a situation where they feel like they have a good relationship there. There's the issues with uncertainty, to think of his future with no break, and I'm doing my best. That was really hard. This mom had like an 8-year-old kid, and she's thinking about at least 10 more years of caring for him and how hard it would be. And then kind of as families adjusted to a new diagnosis of diabetes, figuring out their new family life. Routine is a great thing with kids. A lot of them found that having a routine really helped. Our family is stronger for having type 1 diabetes. We all feel responsible for each other. This was the family with 3 kids. So how can we lighten the burden for these families and kids through school-based programs and school nursing? So that's the real topic for tonight. I love this picture that was drawn by a little 6-year-old with type 1 diabetes. She drew this picture swimming with my Omnipod because she finally got an Omnipod so that her glucose could be monitored remotely. And so then she could finally swim independently. Before that, she always had to stay right by her parents in the swimming pool and couldn't just go off and swim because they were nervous that she would get hypoglycemic and get in trouble swimming. And so this feeling of freedom that she could just go and be a regular kid and swim and have fun was just so exciting for her. So she drew that in this drawing. And I think that's what we're looking for these kids, that they can just have a normal childhood and live their life and not worry about the diabetes too much and just do their thing, have a good day at school. So that's why I love this picture so much. So these are some of the conclusions and implications that I came up with from our research for our family-based programs, and we're still working on developing those. But we thought that we should have multiple sessions with groups of school-age children, siblings, family, and combined. We should tailor the sessions to the specific participants that sign up. We should have those participants guide a lot of the topics. We should look at cognition, communication, care coordination, problem solving, and strength building. Having people share stories and experiences so that they could learn from each other, and that we should really build collaboration between the school and the families in a way that was really like team oriented, would be really positive. So those are the things we're thinking about for our school programs. But then I also identified some specific things for this presentation that school nurses can do, and you guys can weigh in when we maybe when we have our discussion or ask questions at the end from your experiences, and see if there's some suggestions that you have for the group. But encouraging classmates to learn about the condition and encouraging a parent or nurse presentation, especially when kids are in elementary school and maybe they have the same teacher throughout the whole school day or for the whole school year. That can be really positive. That can help everyone to understand what's going on with that kid and encourage that class to be supportive. Encouraging peer support for kids. This can both be like having younger kids being allowed to have a buddy to walk with them to the nurse's office, which can also provide safety, and also encouraging older kids to recruit friends to give support. For example, one child shared a story in our interviews about how she had been up in the bleachers at a school assembly in this big gym at this big high school and realized that her blood sugar was going really low and she didn't have any snacks with her, but she had developed a group of friends that were watching out for her and understood her needs as a type 1 diabetic that would also carry snacks for her. And she realized one of her friends was just sitting a couple of seats away from her, and she asked that friend, "Do you have any snacks for me?" And that friend did. She had some snacks and was able to hand her over some fruit snacks or something that she could eat really quick and fix her blood sugar. So because this friend had peer support, she was able to handle that crisis in a really positive way. And so that's something that school nurses could also encourage. What other friends could you get to help you? Instead of the teenager being embarrassed and maybe not telling her friends about her medical condition, maybe instead encouraging her to build a group of friends to support her. Encouraging peer support for parents, sometimes helping a poorly functioning or newly diagnosed family connect with a family that's functioning really well with diabetes can help them learn some tips or tricks. For example, that family with 3 kids that have diabetes, they have their kids doing varsity sports and they're functioning really well, and they've been able to help some other families figure out how to do that as well. And part of how they've done that is they've enlisted other parents and coaches to help them in the management of their kids' diabetes so that other parents and coaches are watching out for their kids and helping with the cares that they need. And usually people are very open to helping with these types of things. Some other ideas I had were encouraging problem solving, like we talked about. How can the child learn to troubleshoot more independently? Can school nurses coach the child to manage blood sugar and problem solve? And also helping the parent to step back a little bit to encourage that child to do that type of problem solving if they're struggling with managing the child's diabetes. And then we talked about this with what I just mentioned. How can that child with type 1 diabetes participate in team sports and school activities? And facilitating communication with the provider. Sometimes if the relationship can be a triangle with the school nurse, the provider, and the family all involved, if you can get permission to do that, that can be really helpful. And connecting the family with resources. Another thing is preparing the child and family for major transitions, like the transition to a new school, especially middle school or high school, where they're going to be required to be a little bit more independent. At least in Minnesota, we have these big campuses for middle school and high school where they're just farther from the nurse's office. Helping the child to increase independence, helping the parents to let go a little bit, and encouraging the family to meet the new nursing team so that they can get comfortable. Understanding that puberty can be very stressful, that glycemic control may not be as good. The child may assert more independence and self-care and may resist being as adherent to their regimen, and helping the parents respond appropriately to that. Understanding the baseline of stress that these families face, because sometimes it can be like, why aren't they handling this better? But this can be a really hard situation. Encourage positive family coping when a child is struggling with glucose control. If the parent can respond in a way that does not give a negative response to the child, anger or crying or frustration, then the child is more likely to be able to learn in a constructive way. Understanding the uncertainty. Crises can come up frequently and in a way that's very disruptive and stressful for the rest of the family. And that's something that's really hard. It can be really hard to have your day at work be interrupted by a child who's having a crisis. Encouraging teamwork when there's more than one adult in the family, like we talked about. And then lastly, this is my last slide on this, validate that family's efforts. Even if a family is not coping super well, meeting them where they're at, recognizing and encouraging their efforts to support their child can be really important. Recognizing the stress and burden that the parents and siblings carry. There's just burdens of uncertainty and vigilance for all members of the family. And maybe that sibling needs to come and have a little visit in the nurse's office and get some support. And saying to the parent or the siblings, this is a lot to deal with, or I see how hard you're trying, can help them to feel validated, encouraged, and seen. And lending a listening ear is really important. I think it's always important to remember diabetes is a big thing to deal with, just like we saw in that drawing from Lily. So thank you for listening to me ramble on today. I think we all have the goal of swimming like the freedom that is shown in this diagram, this drawing by this little girl of swimming with my Omnipod. This is the article that I pulled most of this from, is Family Interviews Inform School-Based Nursing for Children with Type 1 Diabetes from the Journal of School Nursing. It's one that I'm an author on, but I also pulled a lot of information from other articles, so you can check that out. But yeah, now I'd be happy to answer any questions or take your guys' comments, because I think you're on the first line dealing with all of this.
Sarah, that was wonderful. Thank you so much. So we do have a few questions here. How can the school nurse connect type 1 diabetic students to one another without violating HIPAA?
Yeah, that's always tricky, but I think one of the things is you have a sign up. You say, would you like to come to a diabetes event, you know, and then you create the event, they can sign up, you invite them, and then they come and meet each other. So you don't necessarily say, this is the kid with this is a peer with diabetes, but you could invite them to come and meet each other where it happens, you know, organically that way.
That's a great idea. Next one, I think, is more of a comment, but you can comment back. This is a wonderful program. There is a high school in Kent County that allowed a child to be bullied, harassed because she drank from a water fountain. The kids started a rumor that no one should drink from the fountain because they could catch diabetes. I think more schools should take the lead in encouraging more peer education and support across the board.
Absolutely. That just sounds terrible. Like, we all know that that isn't possible, that could happen. So that's something that really needs to get addressed. So yeah, I think the more we can educate people and help them to know, and you have to do this with permission. If you're going to do an education on that, it has to be because the child and the family want that. You can't do it otherwise, but I think most people usually do. So it's maybe meeting with them before school starts if they want to, and saying, how can we support you and how can we help you? Would you like to do something like this? And it's up to them to say what they would like to do, but offering is a big thing. What can we do? Or this is things we've done before that have been helpful. Would you like to do any of these things? So.
And the last two, we keep getting more. Okay, so I love the pictures. They say 1,000 words. And what is generally the response from sports coaches?
Well, you know, I think sports coaches usually have their heart in the right place. They want kids to be safe, but they also want to give opportunities for participation. So, you know, this is an extra thing to deal with. So, for example, that family with the 3 kids that have diabetes, they had a daughter who was quite good at volleyball. And so the coach was involved with understanding the parameters of the diabetes, but the mom would go to most of the things. And then the times when she couldn't travel with the team, then she had some other moms that would help out. So, you know, it wasn't, you know, it took a village. So the family was really active in organizing that. And that's something that, you know, some people are going to do better than others. It's not necessarily something that maybe the school can completely provide. You've got to have people that you have to encourage them to kind of build their support network. So, and this volleyball player would have her friends carry the extra snacks for her. I mean, they would do all of those different things to cope. So,
this isn't on there, but I got a text. Thank you for recognizing the siblings. I think that's you know, a big factor. But also, how is the Health Commons at Pond funded?
We are chronically underfunded. The facility is part of Bloomington's campus, so we don't have to pay for the facility or like the janitorial support or things like that. But we're constantly applying for grants for like our supplies and things like that. And then my time is paid for through the university that I spend there as part of my academic appointment, because I have nurse practitioner students and nursing students there with me. But yeah, we have an advisory board and we're constantly applying for grants from the Minnesota Department of Health. And I mean, it's like $2,000 here and $5,000 there. And, you know, I have 3 grants I'm working on applying for right now. So it's a battle. So, and, you know, sometimes we offer more services and sometimes we offer less services. The Vaccines for Children program pays for all of our vaccines. And right now, Bloomington Public Health has a big grant to help pay for vaccinating all those kids that are coming in through the border. So we're doing some extra vaccine clinics and they're bringing in the vaccines for those. So we're trying to take advantage of anything like that that's going on, and then they can use our facility. So, you know, we're trying to work with whatever's going on in the community that we can piggyback off of, but it's a battle.
All right, I don't see any other questions. So thank you so much. And with that, we'll turn it over to Dr. Phan.
Thanks for having me. It was a pleasure.
All right. That was, I feel like a really good segue to talk about transitions. But I'm super grateful to be here tonight. I'm in Central Time Zone. I know some of y'all are in Eastern, but and today it was actually 70 degrees. So I don't know how cold it was on the East Coast, but I do also have ties to the East Coast. So I'm originally from Virginia, and I went to pharmacy school at the University of Maryland, and hung around there for an extra year after pharmacy school, and did a residency at Johns Hopkins Home Care Group, and then moved here for a second year of residency, and that's how I ended up here. I always get asked, like, how'd you end up in Mississippi from being from Virginia? And then I practice at a couple different practice sites, but I am mainly a School of Pharmacy faculty member. So similar to Sarah, I think we have similar setups in terms of our academic appointments and things like that. So I have 3 different practice sites, and one of them is pediatric endocrinology. And just to give y'all a, I guess, image of what we are. So we're one of the only level 3 trauma in the state of Mississippi. So pretty large medical center. We just got a new pediatric tower, so that's where our clinic moved to, which is very exciting. And my main role in our pediatric endocrinology clinic is to transition kids from our pediatric clinic to an adult clinic. So I'm a part of that team, and I am one of 3 educators, but again, my main role is transitioning patients, and our other educators do all the educating from, new diagnoses to frequent DKA admissions to all the things like that. So I'm very much just helping our kids go from the peds clinic to the adult clinic. So how did this come to be? So this is something that one of our previous providers was really passionate about and just wanted to move it forward. So she started making a policy on it, but she went to a different health center. So we never got a program. But then when I came on as the clinic pharmacist, this is something that I think, just from my different experiences at different health systems, I felt like something that we could benefit from. And I know we have obviously school nurses on, as well as I think there are some parents that have kids living with type 1 diabetes. So I think some of us may find this relevant even in our own personal lives of transitioning. But I think ultimately for us as school nurses, pharmacists, dietitians, all of that, we all play a role in transitions at some point. And we play a bigger role than maybe we even think we do, especially when we come in contact with some of our kids every day. So with that, I am hoping by the end of this that we'll be able to talk through a formalized transitions process, be able to talk about like the skills that are expected at each age. I think we come in contact with so many different kids of different skill sets, of different maturity levels. Even, one 8-year-old is different from another 8-year-old, and one 13-year-old is different from another one because of a lot of different things. But I think it's just good to have us all on the same page in terms of expectations, and we'll go through all of that. And then the last thing we'll go through is, like, let's say in Delaware that we have an opportunity to do something like this. If we were able to create a transitions program, or if we already have one, how you would go about that, and how we did that here at UMC or at the University of Mississippi Medical Center. So just to start out, this is a quote that's from ADA, so the Diabetes Care Journal. So in terms of transitions, like setting the stage for like why this is important, I think all of us probably can come up with a couple different reasons of why we think this is important, but I think it's just so important to make sure that our kids have the tools to be able to move to the next steps of their life, whether that be, making sure that they know how to, manage a low on their own, or if there's an acute emergency, or, just making sure that they are doing the best they can to make sure that they're not at risk for any of the chronic complications of uncontrolled diabetes, and making sure that that they live their most healthy and normal lives as best as they can. And also, I think Sarah really touched on a lot of this, but also making sure that we handle the psychosocial, emotional challenges that we've talked about over the last 2 days as it relates to diabetes. So what is the purpose of a transition? So one, like I said, is to make sure that our kids have the tools that they need to be able to move to the next steps of their life. I know a lot, at least for us, our demographic in Mississippi, a lot of us have a variety. Like some of our kids go to trade school, some of our kids go straight into the workforce. Some of our kids go to college. Some of our kids, they call it junior college or community college. I know being from the East Coast, I hear more community college, but from here it's called junior college. And then our second goal is to make sure that we have an organized process. There's a lot of studies that say, hey, if we have this available and that we do it in an organized way, parents are more open to, having their child like go through the program or making sure that they receive the information at each step. And I know in terms of, I don't know, for personally, I feel like for me, I tried to hold on to my pediatrician as long as possible. So I'm probably one of those that probably should have been asked to find an adult provider, a long time before I was personally ready. So I think having something like this and making sure that everyone involved is comfortable, especially when we're dealing with diabetes, to make sure that everybody has the tools. Because a lot of times I'll bring people into the room and I don't think it's maybe the patient that needs the most transitioning. It might be the parent or the sibling too, like Sarah was saying, how important siblings are as well to all of this. So I think lots of different reasons why this is important. And of course, transitioning not just, like I said before, the patient, but also everyone involved. And then also like, this is different, right? Like this is a chronic disease that we will handle or have to handle the rest of our life. So just making sure that we have the tools that we need. So a formalized definition of what it is that transitioning is transitioning a child or a family from a pediatric model to an adult and patient-centered model is what we're going to be talking about. Because I know a lot of times we think about transitions of care as like inpatient to outpatient or transitions of care could be a lot of different things, but for this presentation specifically, it is pediatric clinic to adult clinic. So what is let's say we're going to start this. What do we need to think about? What are the core elements that relate to transitions of care? So like I said before, we had a provider that was very passionate about transitions of care. They created a policy or a guide. So where do you start on that? What kind of things do you need to go into that policy? So thinking about age that you want to start, because technically transitions should start the day that we're probably diagnosed with diabetes, technically. I know there are a lot that go into the diagnosis and we're probably not ready for any of those things, but I think there are things that are transferable that we're teaching all of our kids at the moment of diagnosis that is helping them transition without us really realizing it, right? So that's the first step, creating a policy that everyone agrees on, all of our providers, and it definitely it sounds like we need to communicate better with our schools, obviously, because you're the ones that see our kids every day, and can definitely assist with this process. And then from there, of course, planning, like who's going to be in charge, who's going to own this process, thinking about all those things. How are we going to monitor which kids have been seen as a part of this program? What part of the program are they currently at? Like, they've only had 1 visit, 2 visits, 3 visits, what's going on? How do we track all of that in our electronic medical record? And then also just seeing how ready everybody is, including the patient, family, caregivers, etc. Just making sure everyone is ready for this process. And then of course, transferring the care. So having somewhere to transfer the kids to, or now our young adults to. So lucky for me, we have something called like internal medicine and pediatrics here at the University of Mississippi. So a lot of our kids end up there as like their primary care. And then also we have endocrinologists that are med-peach trained. So a lot of times they get transferred to them because they maybe love transitioning and helping young adults with diabetes. So it works out great that we have that training and that available to us, but I know that's not always available. And also, I don't know what y'all know about Mississippi, but in Mississippi, it's definitely a sometimes a desert in terms of having certain specialties. So some of our kids drive like 3-4 hours to get to our center, and it's a very rural state. And then in terms of the last step, so just making sure that we complete the transition, that the patient makes it to their visit, that they have someone to see, that they have someone to get their refills, and that, you know, that they have moved on and have secured a spot in the adult clinic or adult care. I think some questions that might come up too is like, and could be a possibility, is like, what if you don't have an adult endocrinologist available? What do you do? If there's primary care providers that are comfortable with managing type 1 diabetes, that's fine. But I think it is recommended that we keep all of the care at an endocrinologist if possible. So moving into our second objective. So what are we expecting our kids to know, and how do we know that they know how to know what to do? So in terms of ages, I broke this down. It might be a little bit small for some of us, depending on how we're viewing the presentation, but hopefully this will be available for you to look at later. But in terms of thinking about like our younger kids, so 3 to 7, just making sure, and this is a nice breakdown of like what they should know in terms of their diabetes milestones versus like what we can do as caregivers and healthcare professionals to make sure that they're working on getting these skills accomplished. I know like right in the beginning, you know, the parents are usually the ones doing everything, or y'all as nurses and educators and all of that, you're in the classroom managing probably some of this as a part of your classroom too in the beginning. But how do we incorporate the kid into their care and build them in terms of building them up to be able to do these things independently, but not too soon? I think a lot of times I see that a lot in clinic too, where some of the kids have been doing this maybe a little bit earlier on than maybe they should have been expected to, which may lead to other things that we may not want. So in terms of our ages 3 to 7, making sure that they're aware of what hypoglycemia is and how to potentially prevent it. And obviously using different terminology based on how old they are. And then of course, being able to cope with maybe not having an appetite, being a picky eater, being more active, especially with our younger kids. And then just making sure that they're able to be present and available for their treatment, you know, be there and explain, you know, what we're doing if we are giving insulin doses, why we're doing that in the best terminology and wording possible that's understandable to them and where they are developmentally. And then of course, like for us, also trusting you know, what happens at home and what we do at school as well. And then caregiver roles, like I said, is just educating as best as we can, and making sure that we ourselves, and this is more geared towards parents and caregivers in addition to healthcare providers, but not getting burnt out with the management of their diabetes, and reassuring. I feel like a lot of times in the beginning and when our kids are younger, people think that it's someone's fault and they have a lot of guilt and all of that, but just making sure that we play a role in making sure that it's not anybody's fault, and this is something that we're all in it together and we all have a common goal of making sure everyone's safe. And then for ages like 8 to 11, I think all of this is just like step up, right? So from 8 to 11, just learning more about like short-term and long-term benefits of having controlled diabetes. What does that mean? I don't think that means like scaring anybody or withholding anybody or holding any kind of information over anybody's head. It's more just explaining so that they have the tools that they need and know, you know, what to expect. And then I think communication is a common theme throughout all of this in terms of the caregiver roles. And then as we get a little bit older, making sure that I think Sarah also talked about this, but like how insulin requirements may change during puberty and puberty itself, what that means in terms of changes, in terms of mood changes, how our body changes, all of that, and how that might relate back to, that might mean that our body needs a little bit more insulin, and we might deal with different things differently, as you see there, recognizing weight and body image concerns, as well as, again, this might be more of a period of like burnout for a lot of kids. And then, of course, Sarah touched on this, but caregiver roles in terms of monitoring for signs of depression, eating disorders, or any other risky behaviors. I think we are in a great role for that, especially with us being in the school systems And then making sure that we are preventing and intervening in any kind of diabetes related conflict. And sometimes we might be that middle person in terms of conflict that may arise between parents and kids. And then just making sure that we're assisting in their coping skills that they're developing at this time, and to make sure that we're helping them self-manage instead of just doing it for them. And identifying, if someone is ready to do things independently, just making sure that we don't give them too much independence or not enough, so just being mindful of that as well. And of course, the next step up for 16 and 19-year-olds, just making sure that we're talking about like next steps when that starts to become a thing, like if we're entering the career field directly, or if we're going to community college, junior college, or a 4-year university, like what does that mean in terms of management of our diabetes, and just encouraging independence. So I think each step of the way, we are so essential, all of us, and making sure that everyone is able to make it and progress through all of these milestones. In terms of blood sugar management, this goes through, again, like the different skills at different ages. So I think I don't have to read through each one of them, but I think we probably see all of these on a daily basis in terms of depending on the kid's age. And a lot of these all involve our school nurses, which is great. And I think the biggest thing is, like I said, just making sure that they're developing at each part. Sometimes we might miss packing our bag with snacks, but not scolding them for it, right? Like just re-encouraging and redirecting and making sure that we have the things we need so that they're successful. I see that sports, are also brought up here in terms of like what they need to do when they are playing sports and all that as age appropriate for that 12 to 15 point. And then, yeah, I think just really unifying and making them think like, what's the next step from each age step. And then age appropriate skills, generally speaking. So this is what we should expect, is like from ages 3 to 7, that parents, caregivers are doing everything, but still teaching and giving them exposure, and, and especially if they're ready to be independent in certain areas, of course, observing, teach back, showing, all of that. And then ages 8 to 11, obviously doing the task, but we're, supervising. And then from 12 to 15, we're there just to make sure everything's okay, step in if we need to. And then of course, 16 and 19, just, offering more of the support if needed. But hopefully they're able to do most of the self-management aspects by themselves. So what does that mean for all of these too? So like if they're giving their own insulin injections, checking their own blood sugars, putting things into their pump. I know a lot of times like we'll just like take a pump and just put things in and put carbs in. I know here, like, we'll have dietitians that like circle what meals we're having each day of the week. And then like our school nurse will just put in the number of carbs instead of telling them to do it, or, telling the child to put it in themselves. And then we just confirm. So I think little things like that go a long way in terms of helping them grow their own independence. Maybe we make them circle the meal themselves and they select it, because empowering them to pick their own things and then add up their own carbs, and we just double check, And then also like just knowing how to keep our blood sugars in target is a part of these skills in general too. So as we progress, and I think overall, like I said, just making sure that we get them thinking at that last part too, like what are our next steps? How are we going to incorporate? And then in terms of what we do at UMC, so like I said before, how did this come to be? So for me, like I said, this is something that I think is important. We probably spend too much time sticking to our pediatrician and hoping that we can hang on for as long as we can until we're 26, until the insurance runs out. But I think ultimately you can usually tell with most kids when they're ready, or if they're ready in their next step to move on to the next thing. And like I said before, transitions is important, ideally when we're first diagnosed, and more of a longitudinal thing instead of just a just in time, just as needed thing. I think that goes a little bit more smoothly if we're able to start the process at each step instead of just doing it all at the end. And then in terms of, like I said, we already had a policy going, and it was just a matter of like setting up everything in our electronic medical record, telling parents about it, that we were starting this, and then going from there. So offering it and trying to identify our kids that were about to be transitioned and starting there, and then working our way down in terms of the ages, in terms of what information we make available to our kids that are less than 18, 17, 16, and going from there. So what does the timeline look like? So like I said, for like our 12 to 15-year-olds, just making sure that they're comfortable with doing each of the things independently, with the supervision. Of course, I definitely have a lot of parents that sometimes are like, oh yeah, they do everything on their own. And, you know, and sometimes we're not able to be there, right? I have families that are like, I work like night shift. So like I'm doing the best I can. So, you know, just also being a nice listening ear too, in terms of if there are different situations like that. In terms of like our 16 to 17-year-olds, that's when we're more like, all right, so what are our goals? What do we want to do when we grow up? Okay, let's think about how that involves what we're working with here. And then the next step, like 17 to 18-year-olds, okay, let's think about where we want to be, if we're going to college, is there someone we can see when we're there, or do we want to keep all of our care here when we come home for breaks? Thinking about just education that we're providing based on where they're going. So like, for example, I had a kid that was working at a bakery when he was done with high school. So, and he was like working in the freezer part of the bakery. So like trying to talk through out loud, how is he going to monitor his sugars? How is he going to hopefully not have all the treats that he's working with at the bakery, or, you know, in moderation? Or how are we going to store our insulin if we're working long shifts? Just things that I think, just making it very individualized as best as we can. And then of course, I think a lot of parents are worried that we're like trying to kick people out of clinic. And I'm like, oh no, like this is a personalized like process. We'll work with you when everyone is ready. So the day we turn 18 is not the day that we need to find an adult provider. We'll work towards that whenever everyone is comfortable. And then in terms of what I do at our clinic is that I usually try to, if it's like a later initiation of the process, like we're doing it because we're 18 and we're ready now, I try to do 3 visits. So the first visit is typically, and we'll go through the slides and we'll see the different topics that are covered, but I cover different education topics that we have. And then obviously get more information about the patient, because I'm not the one that has been seeing them the last 10 or more years. So getting more information about them, what are their goals, aspirations, same with the parents if they have any concerns as it relates to the transitions process, same with siblings, family members, caregivers, everybody's involved. So whatever concerns anyone has, I listen to those and just really try to think about how I can gear the education and make it relevant for what they need as a whole. And then I split that up over 2 visits. And then the third visit is typically like reinforcement of all that information. So I have a interactive class that is individualized to the person. So I'll do different scenarios. I talk about, like I said, we'll go through all the education topics, but one of them is like what to do if you come into contact with alcohol and you have diabetes. What do you do in that situation? So we talk through that. And I stress that you are not of legal age, but if you ever wish to, when you are of legal age, this is what you can do. So just creating a safe space too, to talk about things like that may have not had, the space to ask about those things during their regular visits. And then that use prior to COVID, that the intention of that was to do a group class where they could meet other people. And, if they didn't want to do it with other people, that's okay. We can make it individualized. But after COVID, we just made it a one-on-one session. So in terms of how we stretch that out, let's say at each age, so like if we are transitioning earlier, starting the process in an appropriate amount of time and earlier on, I try to meet with each of the patients at least annually and talk through those different skills that we talked about earlier, in terms of just making sure that someone has evaluated and made sure that they can do these skills independently or under supervision, depending on how old they are. And then in terms of the topics that we talk about, each divided between the 2 visits. So the some of the topics include just talking about like type 1 and type 2, just gauging their knowledge of what that may mean for them, and if they had to explain that to someone else. What does A1C mean? What labs do we get every year? You know, I know that might be a traumatic time sometimes for some of our patients, so they might block that out, but really understanding why we get those labs and what they're for, and why it's so important to make sure that those are drawn wherever you go and whoever you see, that they're drawing those labs. Pregnancy health and just conception health, and just making sure that our patients that may be interested in that, I know a lot of times I get a variety of responses when I bring that up, but if they're interested in talking about it, I at least give them the basic information in terms of like diabetes requires very strict control if we were to conceive or be pregnant, and just leaving it there. And if they want more information, I can provide more. Just making sure that we know how to manage our own ketones independently without caregivers, parents, or if we have partners, spouses, boyfriends, girlfriends, roommates, coworkers, that we know how to let everyone know about, you know, in terms of ketone management or hypoglycemia management, so that everybody else knows what to do. And then, of course, carb counting. So this is a big part when talking about everybody on the team. So we are all a team, right? So we have dietitians in our clinic, and of course other educators, but we have educators that are also trained as dietitians. So they are perfect in terms of talking about carb counting, thinking about what to expect in college campuses, or how to look up, like if we're eating out a lot, in terms of Taco Bell or wherever we're deciding to go when we're a freshman at school. So we have great resources to be able to talk them through how to figure that out and how to manage that, or whatever their concerns may be related to food and the foods that may be available at college or at our new workplace if we're transitioning into the workplace. How are we going to figure all that out? Because now mom, dad, family is not just putting the food and telling you how many carbs there are in it. You have to do that on your own. So that is important. And then, of course, talking about the different kinds of insulins, and talking about exercise management as well. So I know we talked about athletes earlier, but just making sure if we're not all athletes, but we're just going to the gym or going for a run, knowing and making sure we know how to manage those things. So like I said before, we go through like real life scenarios. We also go through how to pick an adult provider and how to prevent the lifelong complications by having controlled diabetes, and then planning for the next stage of life, which I've talked about quite a bit, and the purpose of all this. Managing prescriptions. I think sometimes we think this is like intuitive, but it's not, and it's sometimes complicated, and some of our kids are shy in terms of talking to people on the phone. Some of them don't even like talking on the phone. So depending on who it is and what it is, I sometimes say, hey, you have a smartphone, let's take it out, download the pharmacy app, because some of them are 18, so they're able to sign up, make their own account, and manage their prescriptions. And we make goals between each appointment, like, hey, next time you manage all your prescriptions, if mom, dad, caregiver, you're okay with that. So we discuss all that in the open and make sure everyone's okay with it. Or if they don't want an app on their phone or they don't have a smartphone, I ask them to call and we walk through it together. How do you do that? And we coach through it, how to look at your prescriptions. How do you know when you're running out of refills? What do you do when you don't have refills? Just talking through all that, because I think those are things that we assume we learn at some point, but no one ever goes over it. And of course, supplies too. Like for here, everything is usually required. You get it through a DME company, so a durable medical equipment company. So it's usually like shipped to you in your house. So knowing how to call those people too. So now you have all these phone numbers that you need to put in your phone, and most of our kids have smartphones. So I just ask them to plug all these numbers in and label them so they know how to get there and reach who they need to reach. And then, of course, managing doctor's appointments. It depends on the family, but sometimes we're able, once they're 18, we ask if they're okay with switching the phone number or maybe a secondary phone number, or keeping the parents' or caregivers' phone numbers as a secondary number and theirs being the primary, to manage their appointments and appointment reminders and all of that. And this is a big one, is navigating insurance. So in the state of Mississippi, most of our kids are on Medicaid. I would say the population of patients that we see too are on Medicaid. So figuring out a plan, because I think a lot of times Medicaid stops at 18 for us. During the pandemic and COVID, the height of COVID, there were some loopholes where people had Medicaid for longer than most of the kids did prior to the pandemic. So just making sure we have a plan, whether that be doing exchange insurance, getting on our parents' insurance through their employer, or getting it through school if those are our next steps, or your own employer if they're entering the workforce. So talking through all of that, we get into a little bit of what's a deductible, what's a copay. We have a good time with all of that. And then also just working through like how we feel about transitioning, our feelings. And this is a good point for our counselor to be involved in terms of just coping, how to cope through the transition, adjusting, problem solving, and just, helping us with our mental health. So we have a counselor at our clinic. I'm fortunate to have one. And then, of course, for the navigating insurance, that is very helpful to have a social worker. So we have a social worker on our staff. So sometimes they can help us in terms of thinking through what our options may be or what we can do once Medicaid is no longer active for us, once we turn 18 or 19. And then, so we went through our roles of everybody. And then in terms of like the next steps too, like involving our nurses. So we have nurses that help with making sure that we have an adult provider. If it's an outside adult provider, that we get all of the records that we need to go there. And we have like LPNs too that assist with all of that, and making sure that we have an appointment set up, when we're ready for that time, and that we have, that provider has all the documents that they need to be able to transition care. And then of course, our other educators, any of us can do all of these education topics, but I'm the main one that works on this process. And then in terms of course, our providers, their role in that is just recognizing when someone may be ready. So, and just telling the parents about this process and that this is available to them. And if they would like to be a part of it, it's not anything extra. It's just part of the care that we're providing. And then just to go through a little bit more in depth of like what I do from visit 1 to visit 2. So initially visit 1, I have this survey that's from the Endocrine Society that we're allowed to use through IRB has approved us to use this and keep this on record at our institution. So I usually give this to the patients and get their like pre and post. So so that we can identify as well as work on any areas that they might have any challenges in. So it goes over like, am I challenged by any of my diabetes burdens? How is my social, emotional, and cognitive areas going? So it asks a lot of questions of like, compared to like my peers, how do I compare? Or like if I often feel sad or blue, or if I worry about the future. And if I don't have an exact number of like, hey, if I answer that I always, feel worried about my future, I always feel sad or blue, that we get like an automatic consult to our counselor. I think automatically I just offer no matter what as a part of the transitions process, and to make sure that they at least see them at least once, or offer in case. And then of course, the third section here that you see here on the screen is like transitioning and preparedness for that. And I find it very interesting how many of them mark, like I know what my insurance covers, I can make doctor's appointments by myself, I can refill my prescriptions, and then we talk through it and it's a little bit of a different story. So I think I take this and make sure we address everything. And like I said, I do a pre and post. And then here is an example of the age related skills that we talked about earlier, and just making sure we assess them. So this is for our 8 to 10 age group, but I have some for each age group, and it goes through what they should know how to do and if it's been assessed or not. And that gives me a little guide and make sure that I cover that at each step. So this is for 8 to 10. And then we jump up to 16 to 17, but there are ones for the in-between. But I was just trying to show the difference in terms of going from 8 to 10, what we could be independent in doing, and versus 16 to 17. Of course, we have like the 18 to 21 one as well. And like I said, I put all of this in our EMR to make sure that it's communicated, our electronic medical record, to make sure it's communicated and that we all know what has been discussed with our patients. So this all sounds really great, but how likely is all this to happen? Like, how many patients do we normally get? What are some barriers that exist when transitioning our patients? I think this is a very short list of probably the barriers and things that we go through, but I think ultimately, I think I started this service probably right before COVID. And I would say our center has hundreds of patients living with type 1 and type 2 diabetes. And thinking about, like, do I just transition patients with type 1 diabetes? No, we can do both, because I think the skills are relevant to both. But in terms of how many patients I've transitioned, I would say it's probably a handful of like 20. So small but mighty, but I think all the patients that have gone through it and had a successful transition to an adult provider, I think all of from the patient to the parent, they're all very thankful that we, put this effort to make sure that they had everything they needed for their next steps. So I know it's an extra appointment and extra appointments, and might be extra time missed from school or extra time missed from work. But I think it is an investment in making sure that our kids have the tools they need to move to the next step. So in terms of barriers, so a lot of times we get kids bouncing back over and over again, especially in that last 17, 18, 19, 20 years old range, where they are set up to be transitioned formally, and then they get admitted, and then they end up on the adult service because their age, and like they get admitted to the adult because they're 19, and then those patients get lost to follow-up, and they just end up getting an appointment scheduled with an adult provider, and then we don't get to see them anymore. So sometimes that's a barrier. Like I said, another barrier is just being lost to follow-up. Like, at some point they didn't come back after 3 times or 4 times or 5 times, and we kept trying, and we couldn't find them. So sometimes that is a barrier. Because this is sometimes an additional appointment, sometimes I try to align it with their endocrinology appointment with their NP or their MD. But sometimes we get no-shows. Like I said, we get kids from all over the state. Again, this is an additional visit, so sometimes it is extra to get here of all the things that we might be missing to get here. And for a while there, I did try to do like virtual visits to see during COVID to see if that would help with show rates. But we had a whole slew of technology issues sometimes during that time or even I got patients that were, driving down the country road trying to talk to me, and it was cutting out every other second. So I think sometimes it's just more effective to get us in person if possible. And psychosocial barriers. So I think sometimes a lot of these bounce backs that we see, like Sarah mentioned, it's not just they don't want to control their A1C or they're not afraid of the potential complications. It's just they're going through something and need some help. So I'm thankful that we have a counselor to help us through that if we're able to get them to come in and see us and visit with us. So trying to help with that. And then like economic barriers in terms of cost or just transportation or just all of that is also a barrier. Like, I had a kid that was independent, but not fully independent in terms of economic status. So he needed to get other insurance besides Medicaid, but he needed someone else that had a higher like income to be able to sign up. So that was a scenario that I definitely needed a social worker's assistance in, and a caregiver or parent to assist with that so that the patient could be covered by insurance. Substance use and misuse issues come up, or just reproductive health. So we've had patients that, we started the transitions process and they ended up, ending up conceiving, and then they ended up on the adult service. So again, sometimes there's incomplete transitions that occur. So that is also a barrier, but these, like I said, a very short list, but there are probably other ones that I'm missing. And then, so from here, let's say we had a successful transitions. Now what? So what I do for our patients, if they are transitioning on our campus, which I never force them to pick one of our providers or anything like that, it is open to whoever they're comfortable with. And we are lucky to have a lot of adult endocrinology providers in our area, in the metro area here in Jackson. So they have choices. So, but if they do stay on campus and see one of our providers, once I see that first appointment is scheduled, I try to walk them to the area that they're going to, show them like where the lab will be, where they go to check in, and just make sure they know where to park, because that's always a lot on our campus. It's like knowing where to drive and park, and that can be stressful. So I just walk them over there and talk them through all of that, and bring them back to the kids clinic or pediatric clinic so they know how to get there from one place, point A to point B. So we go through all of that, and hopefully it's enough. So overall, in conclusion, so we are here as a team, like I said before, to facilitate a smooth transition from our pediatric to adult endocrinology care. And our team approach is, we go by a team approach to make sure that we focus on each of our individual patients and families. And we work with all of our families, not just having the knowledge, but also emotionally, behaviorally, and psychosocially as best as we can to make sure that everyone's prepared for the next steps. So with that, I will take any questions that anyone has.
All righty. Thank you so much.
Yeah.
So far just one. So if anyone has questions, please make sure you put them in the Q&A box. So where do you get the skills goal assessment charts from, as well as the transition survey? When do you administer this transition survey? She had trouble hearing.
Yeah, of course. So I administer the transition survey at the first visit and then the last visit. So I do a pre and post, and I got these from the Endocrine Society. And then where did I get these skills? I got this from the previous provider that created the policy for this clinic, or the draft policy for this clinic. But I believe this is from the literature. So if you're looking at like skills that are expected of patients living with diabetes or type 1 diabetes or type 2 diabetes, this usually comes up in the literature. And also another resource would be the GOT transitions package. So this is for not just patients living with diabetes, but any chronic disease. Here we go. So the GOT transitions is a good resource when talking about what skills our kids should have as it relates to any chronic disease. So all three of those resources are ones that we use.
Awesome. Any other questions? Give you about 30 more seconds to drop those in the Q&A. Someone did say wonderful program. Thank you. Here we go. Any tips on helping for smooth transitions for type 1 diabetics who also have mental health behavioral issues that create barriers?
Yeah, I think this is a hard one, because I think we probably all go through this in terms of our kids that are struggling with mental health. The best I can do is offer our counselor. And if they don't want our counselor, I really just try to work with them one-on-one. I don't always just hold it to a strict, like, hey, we're doing 3 visits and then we're out. I think that's also why it's so important to start early. So I think overall, step 1, I use our counselor and collaborate with her and see if she has any tips. And I think step 2 is just really figuring out what the needs are and what we can do to help that child and make it more of a comfortable transitions. And then I think step 3 too is like just talking to our providers, because I think we just all want that, like, hey, we want that great control when we transition them, and we don't want to just put this patient that has an A1C of 14 on an adult provider and then think, what the heck did we do? And why are we doing that? But the reality of it is, like, sometimes we've done all that we can, and we've provided all the resources and offered all that we could. And let's say they get admitted with DKA and then they just end up on the adult service without our control. So sometimes that's just what's going to happen. And I don't think we need to like track them down and bring them back to the pediatric clinic. I don't think that's going to offer, that much anything different. So I think if they just end up being transitioned to the adult clinic in that way, I think that the adult clinic should be aware of those barriers and those things, and hopefully they can also work on that as well. Another thing that I just came up with too is what I've tried to do too, if they're transitioning to a provider on our campus, because we have kids that are like, I am really reluctant to see anybody else. Like, I don't even know why you're here to talk to me, because I've been seeing this person since I was 7, so I don't know who you are. So I think what I try to do too is, if I can get the adult provider to come meet them early, I do that, and I have them listen in on things to give them a better perspective of what's coming next, and that they can meet the person and get familiar with them. So I think that helps as well. I know we don't always have access to that in the schools, but we can always tell the provider, like, hey, I noticed this, or like, hey, this would be helpful if y'all had this available.
All right. And just 2 people said thank you for a wonderful presentation. So there, yeah, thank you, Sarah and Dr. Phan, so much. This was very informative. And we do this every year, and we're grateful that our speakers do this at no cost. And you volunteer your time to educate our nurses. And I said last night, we certainly don't have these resources in Delaware. So that's the power of virtual. And we're very appreciative that you guys do this for us. So thank you for being here.
Thank you. If anyone wants to be a school nurse in Mississippi, I will take you. Because honestly, I didn't say this during my presentation, but we have such a, some of our kids have the same nurse for like elementary school, and they have a great nurse, and then they get to high school and they're like on their own. So like we've seen that so much, and our social worker has had to deal with that.
Wow.
Or like
so you
the parent will come in and meet them and be like, okay, like I guess you don't have a nurse, so I'm going to come in and put your carbs in. So
you don't have a school nurse in every school? Wow.
Yeah.
Delaware does have that. I will attest.
So if anyone wants to come, travel nursing to a school, I don't know, but anyways.
Awesome. Someone did ask how they can connect with speakers after this. Do you guys mind if I share your contact information?
Nope, I don't mind.
Okay, cool. Awesome. I will, I have the email ready to go out at 8:30. So I will add that in a follow-up email at a later date, but I'll get that out there. We also are waiting on the slides from last night, but the video is posted on the website. This video will, it has to upload to the cloud, and then I have to download it, and then I have to upload it to YouTube and get it on our site. So it should be up there, if not tomorrow, by Saturday. Like I said, you will be getting an email with the surveys to both nights, as well as a link back to where you can find this information on our website. And now I have all of you on my email list, so you will get notified about this next year, but you can mark your calendar. It is always the second Wednesday and Thursday of February. So we will be doing this again next year. So, and with that, I will put the link in the chat is for your evaluation for this evening. If you don't get to click on that before I end it tonight, like I said, you'll get the email. And I know we're again ending a little early. So if you're still on when I end this, you will get the full 2-hour time frame. So thank you so much, Dr. Phan and Sarah Ogilvie, for speaking tonight, and for everybody for attending. We really appreciate it. Have a good night.
Right.